Dr. Marianne Hopkins and welcome to our programme Top Doc Education. Today we're here to talk about type 2 diabetes and how to decide on a HbA1c target for our patient. I would like to introduce Dr. Mahmood again to talk to us. Welcome Dr. Mahmood, welcome back. Could you please give us a bit more guidance on how to decide on a HbA1c target for our patient? Which target is good, which target is bad, and how do we decide what target we should use individually for the patient?
So as we talked about in the last short video, that treatment of type 2 diabetes become very personalized. So what we now do is individualize treatment options and individualize the target. So the first thing we need to determine is look at the patient as an individual and have an individual bespoke target made for that patient only. And for that we have a guidance, and the guidance came back first in 2012 with the ESD and ADA position statement, which was then updated in 2015. And it clearly says that you need to look into certain factors which are as follows. So first of all, look at the patient's disease duration. So how long the patient has been in the disease, what is the length of period that they were diagnosed there. They are long disease duration or they are short disease duration. So if the patient has had disease for 20 years, then your target should not be very stringent. You should have a kind of a reasonable target, but not so tight HbA1c target. If the patient has been newly diagnosed, then they have a very good chance of all the therapies working, so you kind of have the target quite stringent and tight target. If the patient has had lots of complications, for example, ischemic heart disease, strokes, they have other microvascular complications like neuropathy, nephropathy, retinopathy, if they have previous history of recurrent hypoglycemia. So those individuals, you don't want to have a very tight HbA1c target. You can have a little bit relaxed and less stringent HbA1c target, as opposed to those individuals who've just been diagnosed, so very young, and they have no complications whatsoever. They are disease-free. You can go quite low as you want to, and you can have a tighter HbA1c target for that. Also, the life expectancy and age is very important. So if you've got a patient who's very young, for example, in the 30s and 40s, they have about 4 or 5 decades to live. So you need to start off with them with a very tight HbA1c target, whereas as opposed to those individuals, you have a patient who is in their 80s, quite elderly, they have short life expectancy or they have a terminal disease, then you probably don't need to be so stringent with them, and you can have a relaxed HbA1c target. So, and also it depends on the patient's motivation. If the patient is very well motivated, you would want to have quite a strict HbA1c target, and also the resources that you have. So in summary, looking to the patient's background, the age of the patient, disease duration of the patient, how long they have been in the disease, and the current existing complications, if they have history of recurrent hypoglycemia, and their patient motivation, and depending on that, then choose a target. So generally speaking, we choose a target of HbA1c of less than 7, which is in the new money and new units is 53. A younger patient, for example, if I have a patient who's in their 30s or 40, they're quite young and they have just been diagnosed, I would like to have quite a strict target, for example, such as HbA1c of 6% or 42, which will be very appropriate for them. So all the targets have to be individualized. When you see patients, the first thing you need to determine is what should be their HbA1c target, because that will give you a guidance as to what therapies to choose, how quickly you need to get there. So understand HbA1c as a postcode. So if you want to get to a destination in your sat nav, you need to put a postcode, and then you will then know that how much distance that we need to travel. The sat nav will tell you it's so many miles. It also tells you that it will take so many hours to get there. So you kind of roughly know that you've got 3 months, and then realistically what therapies that we need to choose to get to that target. For example, if the patient is presented with an HbA1c of, for example, 64 or 8% in the old money, then, and the patient's target is now set at 6% or 42, then you need to drop 2% or 22 millimoles And so you need to understand whether you will be able to achieve that in 6 months or 3 months, and what therapies you're going to choose from the outset. So you need to have a plan, and always plan for the next 3 months. So that's how we do it. So in summary, every target is individual, every patient is individual. It's not one size fit all. If you are coming to me as a patient, your target will be very different from an elderly gentleman. So every target has to be determined individually with the patient's characteristics and what they have and in their background. So you need to understand that. Does that answer your question?
Yes, it does. Thank you.
Thank you.
You mentioned the elderly patients there.
Right.
Could you give us a bit more guidance on how to manage these particular patients?
Right. So this is a very good question, because we have a lot of now elderly patients who are in their 80s or 70s who are being treated, and the problem I see here is some of them are being over-treated. So the definition of clinical inertia, which used to be failure to intensify therapy when it is required, there's another part to it, failure to de-intensify therapy when you require. So a lot of these elderly people who are frail and elderly, they probably are in the nursing home or living alone, are over-treated, and especially they are treated with things like sulfonylureas, which carry a high risk of hypoglycemia. So for those, I really request everybody to look into their targets. They might be too tightly controlled, and the fact is that being elderly is not a thing, it's about the quality